Welcome everyone to the February joint session of the VLC, Critical Partnerships to Improve Viral Hepatitis Testing, made possible in partnership with the CDC's Division of Viral Hepatitis. I am Dr. Isabella Chuga. I use she, ella pronouns, and I'm a senior manager here at NASTAD. I am excitedly joined today by the moderator of this session, Clarisse Tsang, Health Department Support Lead, Division of Viral Hepatitis, the Office of the Director at the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, Centers for Disease Control and Prevention, who is joined by Judith, Leahy, SOAR Harm Reduction and Public Health Strategist, Health Systems Division, Viral Hepatitis Program, Public Health Division with the Oregon Health Authority, Gillian, Leichtling, Research Director, Comagine Health, and Erin, Research Manager, also with Comagine Health. So for attendees, like I mentioned, feel free to introduce yourselves and your jurisdiction, and inclusively send your questions through the chat, which will be addressed in real time during the presentations. Really aiming for engagement from the get-go for this session. So feel free to interact with us through the chat. And with that, it's like I'm turning it over to Jude.
Hi, thank you. So Erin, you're going to hit that a little bit bigger. So welcome. We are really excited to be with you today, sharing about the implementation and sustaining our community-based programs to reduce harm. And we're going to be talking about Oregon's Prime Plus program and our new program called UCOPE. And I'm joined by my partners. And I want to say as we start this, that there are many, many people behind this work, including 50 plus peers, supervisors, and other people inside of OHA, health systems, public health, and Comagine. Next slide. So we are going to go through a little bit of background of how we got here. Then we're going to talk about Prime Plus, which was part of the 1702 supplemental grant. And then we're going to be talking about UCOPE, which is our 2103 component 3 activity. So a little bit of background about OHA peer service projects that relate to harm reduction, HIV, hepatitis C, and STIs. So in 2017 and through 2019, we had some siloed peer service projects. One of those is called Oregon Hope, which is one of the NIDA-funded projects related to HIV and overdose prevention and hepatitis C prevention. We also had a peer pilot in our emergency rooms that was funded by our state legislature through what was called House Bill 4143. The House Bill 4143 pilot was then picked up and supported by the state opioid response grant and was called Prime. So in 2019 through where we are today, we started out with our Prime project, and then we had our Prime Plus pilot, which included, it was peer-based harm reduction that also supported people to get screened for HIV, hepatitis C, STIs, and linked into care and treatment. And then towards 2020, during the COVID epidemic, we were able to, by combining funds further, and we were able to expand our Prime Plus pilot sites to where they are now, which we're going to talk about in a second. And then where we are moving now and into the future is we still have our Prime Plus expansion and our Prime Plus sites moving forward, but we have two projects. One is called UCOPE, which is the Umatilla County Overdose Prevention and Engagement work that we're doing, which we're going to talk about. And then we have a project that is also funded by SOAR called Peer Assisted Treatment for Peer-Assisted Telehealth Hepatitis C Treatment, which we're calling PATH. And we're not actually going to talk a whole lot about that project, but I just wanted to kind of here's where we're going with the peer-related work in our state. Next slide. So our siloed peer programs, the NIDA funding, the Oregon Hope Study, is a collaboration between, it's led by OHSU, and we collaborate the Oregon Health Authority's Acute and Communicable Disease Program with Comagine and also with peers who work in a little bit over more than two community-based agencies. So the NIDA funding allowed us to interview people living who were living with substance use disorder and to understand the realities of their life. We developed an intervention. We piloted that intervention, and we're still working on the NIDA grant. And then our health systems division, our behavioral health unit, had the general funds for legislative House Bill 4143 peers and emergency departments, and the SAMHSA state opioid response funding, which was able to support prime peers and peers in emergency departments, clinics, and jails. So when we started collaborating, our Prime Plus peer program piloted in those 3 counties. And then we were able to expand using SOR grants and what we have learned. And we are now in 24 of Oregon's 36 counties have Prime Plus peers in the community working with people. The UCOPE grant is our 2103 Component 3 special project, and we are using that to implement a comprehensive package of interventions for people using substances, people at risk for overdose in one of our Prime Plus counties. And then the other collaborative project that we have is we were able to start a harm reduction supply clearinghouse, which is part of a larger Save Lives Oregon initiative for harm reduction, and organizations that provide direct services to people who use substances and people at risk of overdose and infection can apply to participate in the harm reduction supply clearinghouse and are able to access and order harm reduction supplies that are paid for by OHA. So it's not a reimbursement model, it's that agencies order and then we pay the bill. So our harm reduction supply clearinghouse was initially supported through the CARES Act and is now supported through state funds, including our state marijuana tax and general funding. Next slide. Okay. So what is Prime Plus? So Prime Plus is an acronym, and it stands for Peer Recovery Initiated in Medical Establishments plus Hep C and HIV testing and linkage to treatment. It is an Oregon-based intervention where we work with people who are at risk of or receiving treatment related to overdose, infections related to injection drug use or other substance use, and other health issues related to substance use. Our Prime Plus peer services are offered independent of engagement with treatment or any other program. There are no requirements that a person receiving Prime Plus services be interested or engaged in treatment today or tomorrow. Our Prime Plus peers who provide the services are people in long-term recovery, and they are credentialed by the state as peer specialists, and they receive through our program additional harm reduction and infectious disease prevention and training. Currently, we have 56 peers in 24 counties. And the 24 counties, we have 18 organizations. Some organizations serve more than one county. We have our peers organized in 3 regions: our North region, our South region, and our Eastern region. So how does someone connect to our Prime Plus peer services? Our community partners can make referrals. That includes people from hospital emergency departments, clinics and primary care, treatment programs, syringe service programs. Any community partner can make a referral to Prime Plus services in the counties where we have that program. Our peers also do direct outreach and engage people in the communities. They travel to and frequent and work with people who live in encampments. They reach out to people at convenience stores, laundromats, warming and cooling centers, meal services. Our peers are really creative in that they work with the communities in their agency or are interested in having a Prime Plus peer attend and provide support to their clients. Also, individuals can self-refer to any of our programs. So the services that the Prime Plus peers provide include linkage to treatment and care, including substance use treatment and recovery supports, physical health care, and infectious disease testing and treatment. They support accessing resources. Our peers, many of whom are what are called OHP assisters, can help people sign up for health insurance. They also support participants to access community resources to meet their basic needs, such as food. Our peers also provide harm reduction supplies like safer use kits and naloxone. Our peers can provide peer-to-peer support and provide emotional and crisis support to people. They also support people to reach self-identified goals for health, well-being, and improved quality of life. So the state infrastructure support that is provided to the Prime Plus sites, we have weekly peer huddles by region and monthly supervisor meetings. So we meet together, we learn together. We have a weekly documentation drop-in where people can ask questions about the documentation requirements that we use. We have monthly peer learning collaboratives and quarterly supervisor learning collaboratives as well. Our peer learning collaboratives and our supervisor learning collaboratives, the topics are generated by our programs and by our peers, and we offer free CEUs. We have a program implementation guide. We have topic handouts. We use Basecamp to store a lot of our materials, onboarding materials, including library resources, and we have a cross-site message board. Our peers use an online service database to do documentation. The database that we are using is a customized version of a program called Recovery Link, and our peers that participate in evaluation, they document the services that they provide. We also, because we are funded by the state opioid response funding, our peers do GIPRA, and we also do qualitative evaluation with the help of Comagine. And then I guess at the bottom, really a high level of cross-site support. Our peers support each other, and it is often through Basecamp. Peers will reach out and ask each other for information, support, resources, and etc. Other things. Okay, next person.
Okay, I'll take over the next section. This is Gillian with Comagine Health. I'll share a little bit of information about the program status. So we'll go over some numbers first. Slowness there. So in 2021, the peers served about 2,400 peer services participants. So this is people who agreed to peer contact. This is not necessarily, they do outreach and contact and have relationships with other people who may just want naloxone, but they don't want peer services. So it's 2,400 who accepted peer services. About 50% of those received 3 or more contacts from a peer. So there are some people who maybe they connected at the ED or hospital or some other setting where they might have wanted a little bit of help, but didn't maintain that contact or weren't open to maintaining that contact. So overall, it comes to about just over 12,000 total participant contacts with a peer altogether. There are peers engaged across a continuum. As Jude mentioned, people can be referred to or self-refer or be engaged through a variety of ways. 19% actually did come from hospital emergency departments and 17% from community health clinics or other healthcare provider. You can see that 16% referred, either they were self-referral or a loved one referred them. So this is the word of mouth getting out in the community about the program and people going up to peers or contacting peers in another way. And 15% were through direct peer outreach, the outreach on the street outreach, encampment outreach, other sites. There were 14% who did come from a substance use or mental health treatment program. So those people might have been referred at discharge or if they were leaving AMA, or in some cases, for example, a substance use provider may not have the capacity to provide Hep C testing and treatment, for example, and make a link to Prime Plus peer. So this is a small sampling. This slide is a little bit busy, just to give you a flavor of the kinds of things that peers do with their peer participants. So, for example, 53% of participants worked on or created new goals with the peer support specialist working with them. Just under half had physical health discussions where they talked about their health needs that they might need support with, mental health discussions. And 43% of participants received crisis intervention or emotional support. Recurrence of use preventions were common, and about a third of participants wanted that kind of engagement. And there's just a wide variety of other services, including providing transportation to appointments, assistance with housing, harm reduction, appointment attendance, et cetera. Okay, let's switch to the next slide. So specific to Hep C testing and treatment. So peers support Hep C testing first in a variety of ways. They normalize the conversations about risk testing and Hep C status. And they also provide rapid testing. So there were a few sites who were able, where the peers were able to provide rapid testing. The organizations were CLIA waivered and the peers were trained. Most weren't. Most of the sites provided linkage to the health department or linkage to specific providers in the community that they performed a relationship for testing. Peers also supported the linkage to Hep C treatment. For those who are positive, they assisted with enrollment in Oregon Health Plan, Medicaid, navigation to pre-treatment testing and linkage to providers. And of course, they provided support related to adherence, assistance in picking up their medications at the pharmacy. The peers would contact people to see how they're doing with the medications, if they have any additional needs, side effects, and they support the participant in reconnecting with the provider for any follow-up appointments and for SVR12, for example. Hep C testing and treatment. So in the Recovery Link database, we have documented 430 participants tested for Hep C. And among those, 72 or 17% were recorded as tested positive, and 20% had recorded receiving or received treatment for Hep C. And one note to share is we know from our discussions with the peers that reporting from sites is incomplete, both on the testing side and the results, and particularly the results. We are doing a lot of work now to streamline the online database to reduce missing data. The database that was a really good database that was developed for recovery community organizations, and they made an adaptation for Prime Plus and kind of added a module on Hep C testing, but it was a little difficult to reach, challenging to use. And furthermore, there were some other challenges as well, which we'll talk about in a bit. So we know that both challenges, both to Hep C testing and treatment and to documentation of that. So we'll get into that in a little bit. So the peers collected GIPRA questionnaires, this sort of needs assessment, substance use and quality of life needs assessment survey or questionnaire at intake and at the 6-month time point. And we saw over time, over that time frame, significant changes, so statistically significant changes in decreases in the days of illicit drug use in the past 30 days, decreases in emergency visits for substance use in the past 30 days, and increases in things like being currently employed or ever having an HIV test. There were quite a few other results. I just pulled out those that were notable for the purpose of the presentation. So overall, some Prime Plus program successes. A key one is the statewide peer network built that we were able to support. OHA and Comagine supported building this network. The cross-site support has been a really important ingredient so that the peers, there are many agencies throughout the state have employed peers in the past. And those peers worked in isolation within those organizations typically. And so this infrastructure gave them the opportunity to share practices across the state, to feel for peers and their supervisors to feel like they're part of a network of communication and part of a network of support. Peers are also making changes in their communities. They've reported to us around the kind of outreach and visibility is starting to make changes around the partnerships in terms of agencies and providers reaching out directly to them. Whereas for a long time, they were kind of knocking on doors and doing presentations, and now it's starting to bear fruit in stronger ways. And also seeing increased community support for harm reduction. The peers and the peer teams have done a lot of presentations within their communities around sort of why harm reduction and what it means. They've been successful, again, in developing pathways, referral pathways into Prime Plus, and doing that direct peer outreach so that they build word of mouth. Successes are just distributing harm reduction supplies to keep people alive, keep people safe. And then the peer workforce professional development, you're able to get CEUs and get a lot of training, cross-site training going so that there's a more consistency in approach across the state. Some challenges. staff turnover and workforce shortages have been an issue throughout the project and continue today. That's not uncommon in the substance disorder treatment and recovery workforce, and as well as harm reduction. So lots of burnout, and sometimes it's positive turnover. People move on and get promoted, but there's also challenges with both retention and recruitment. Many sites did experience challenges gaining access to EDs and hospitals. I know we showed that 19% came from EDs and hospitals. That was the primary source. However, many of those come from a small number of sites. A handful of sites have built really strong connections, and a number of sites are still working very hard to try to get access to EDs and hospitals during the time of COVID. Not easy. Lack of low barrier housing. The peer teams have repeatedly expressed concerns about this, and I know that's a common problem in the West particularly, and here in Oregon. So housing in general, and then low barrier housing for people with active use. Fentanyl overdoses are continuing to increase within Oregon, and that's something that's felt by the peer teams, particularly in the last 6 months or so. And also challenges accessing Hep C testing and treatment, which I'll talk about a little bit more right now. Example challenges: most peer sites were not able to provide rapid testing during the pandemic. So testing got a lot more difficult. Many sites the peers were not able to provide transportation during periods of lockdown or periods of surges. So they had difficulties driving people to get tested elsewhere. In general, in Oregon, there's many of the rural sites in particular experience a lack of local providers or Hep C treatment providers. Some providers continue to deny care to people who use drugs. They misperceive coverage restrictions. A few years ago now, Oregon changed the coverage restrictions within Medicaid, loosened the rules to allow people who have active use. It doesn't remove the sobriety requirement, but many providers don't know that yet. Participants in general have had challenges scheduling and attending appointments, phone access, transportation, housing instability. And those are things that the peers support in resolving, but of course are continued challenges there. Solutions that are in progress are: the state has worked very closely with OHSU in particular around promoting hepatitis C provider expansion, and is trying to work with many of the CCOs, that's our version of the accountable care organizations, to try to expand the number of providers that are out there. And also OHSU is offering an ECHO for Project ECHO telesupport for Hep C providers. And our team, OHA, Comagine, and OHSU, are working together on piloting this peer-assisted telemedicine Hep C treatment, which is going quite well right now. And I will turn it back over to Jude for the next couple slides on sustainability.
Okay, so one of the things I always think about when I hear people talk about programs is how are they paying for it and how is it sustainable? So we have been able to use the CDC funds, the 1702 funds, I'm speaking of Prime Plus right now, and leverage state overdose response funding. That was possible, frankly, because of the work that we did with the Oregon Hope Study that allowed us to take this syndemic approach and work with partners that we hadn't worked with before on solving problems together. And so working on when we wrote the 1702 supplement, we were able to reach out and have an authentic partnership because we'd already been speaking and working together. And then as 1702 we knew was limited, we worked from the very beginning of the project to thinking about how we could potentially sustain it and where it would potentially align. And the SAMHSA SOR funding seemed to be the best fit for us to maintain and expand the project. I would say COVID-19 has been doing this work during COVID-19, kind of the beginning of COVID-19, because we launched right before, has been both professionally rewarding because we were able to absolutely partner because we didn't know what we were going to do, and has enabled us to do things that we probably would have taken years to believe that we could do, such as all of the online support that we're able to provide peers and how peers are able to work with one another. So we did try to add peer services outside of people who say they want to engage in substance use treatment. So peer services, you can get reimbursed in Oregon if you say, I want substance use treatment. As you start that process, someone will reach back out and kind of appear to help you. But we were not able, we included, but we're not able in our Medicaid 1115 waiver application to CMS, come back in and scoop up our Prime Plus peers and the harm reduction work that they do. I hope that that is something that as we continue to evaluate our project, we are able to present that information to CMS because we do, this is one of the reasons we are absolutely trying to understand why and how and what parts of it are core and what work, because having a billable peer service and integrating that is our sustain, it's how we can sustain something and grow that better for people with people in our state. Marijuana taxes. Most of our Prime Plus sites have applied to receive funding through ballot measure 110, which was Oregon's drug decriminalization, as part of local, what are being referred to as BURNs, behavioral health resource networks. Those applications for funding have been submitted, not awarded, but it's one of the ways that our Prime Plus sites are really seeking to be more independent for themselves. And then also the statewide infrastructure, we believe, is really a critical component of implementation and sustainment. Our sites need support over kind of, when we say oversight, meaning if we hear something, really taking that community-based participatory approach to it, we're able to ask other sites are able to work together, we're able to have discussions together, so that peer programs are not kind of out doing work and not having anyone to ask questions of. So networking is really critical with our straight infrastructure and that cross-site communication. So that's our funding. And one of the things that we've been cautioning people who say, oh, I'm just going to pick up your model and apply it, is that it feels like to us an iceberg. There's what you see about Prime Plus, and then there's all the people, including our peers, that make it work, the statewide infrastructure. Next slide. So these are our collaborators. And I think I mentioned before, acute and communicable disease and health systems division, our behavioral health, have really deepened our collaboration using our syndemic model that we developed through the OR Hope study. That's person-centered, not disease-centered. We have joined together in overdose strategic planning and also in planning the next phases of our Hep C testing and treatment expansion. Our state opioid response grant is funding a buprenorphine hepatitis C treatment echo. So that has been able to expand and start discussing with us with our Medicaid. We have no, anyone on Medicaid can be treated. And so we really need to support that workforce to learn how to work with people who are currently using substances to get their Hep C tested and treatment completed. I can't say enough about our collaboration with Comagine. I feel like in many ways, they are glue that keeps us all working together, and they help maintain our joint work with OHSU, which is the Oregon Health Sciences University, and the staff up there. So working with Comagine Health, our community partner, to do the kind of nuts and bolts has been really important. And then of course, the collaboration with our sites. It is really and truly bi-directional information sharing about what's happening on the ground and solutions. And I think Erin's going to talk a little bit later about buprenorphine and Oregon's struggle with buprenorphine. And that is an example of this type of bi-directional communication. Okay.
Great, thanks, Jude. So I'm going to talk briefly about the newer project, UCOPE, which is the Umatilla County Outreach Prevention and Engagement Project. Next slide, please. So this project is a shift to a community-wide approach with one of the Prime Plus counties, Umatilla County. And the goal of the project is to integrate, coordinate, and implement a comprehensive package of interventions to improve access to preventative, diagnostic, and treatment services for people who use drugs in the county. Next slide. So funding for UCOPE started in May of last year, so we're still pretty new in the project. And our first project meeting actually happened in July. And we've been meeting regularly for about 6 to 7 months, and we've been able to actually move things pretty quickly over that time. We've successfully formed a really strong project core team, and we're using a collaborative leadership approach that integrates and respects and really elevates the voices of people with lived experiences of substance use. So the core project team includes people with lived experience of substance use and people from organizations that provide services to people within Umatilla's service bundle for people who use drugs. The core project team meets weekly, and we've maintained a really high attendance and engagement rate, which has been exciting and has pushed this work forward. The core team co-developed a mission, vision, health equity, and value statement that has guided the development of all the materials that we've created for this project so far, including a rapid assessment that we've completed, and is also going to guide the development of a comprehensive service delivery model that we're actually just starting to work on now. So as part of convening the core team weekly, we've already led to some really, we actually call them small wins, but they're actually, some of them are quite big wins that we've been able to do together through our collaboration. So we've been able to identify a cost-effective syphilis treatment coordination solution. So some of the organizations that are part of the core team were identifying a gap in syphilis treatment services, and we were able to work together and reach a solution. We've also been able to support implementation of syringe drop boxes across the county and continue to provide that to support 2 organizations who are actually working with neighboring counties as well. And we've been able to connect organizations to the Oregon Immunization Program and connect organizations to Oregon Save Lives and the Harm Reduction Clearinghouse that Jude has mentioned. We also convene key partner meetings quarterly, and this includes a broader range of individuals who provide services to people who use drugs across sectors across the county. So far, we've met with the key partners twice, and that has looked more like us giving them information, kind of building rapport and getting some buy-in for folks. The hope moving forward is that's going to turn into more facilitated discussions around how organizations can work together as we build the service delivery model and really try to get buy-in and think about sustainability of the model. We've already completed a rapid assessment of the community needs, and that includes surveillance data, program data from service providers. We also conducted interviews with people who use drugs and people who provide services or engage with people who use drugs in the county to really get a sense of what's going on and where the gaps are, so that as we create the service delivery model in the upcoming years, it's really attuned to what people's needs are. Next slide, please. There's been challenges. So Umatilla County has been impacted with high rates of COVID and overdoses, which has personally and professionally touched many of our core and key partner team members. The infection and overdose rates highlight why this work is important, but it's also impacted consistent staffing on the project, meeting attendance, and our ability to continue to move the work forward. Fortunately, the collaborative leadership approach that we have put in place and the passion of our various partners has created a project environment of support and compassion that has kept the work moving forward. As project members or organizations have had to step back from time to time in order to take care of themselves or their staff, other project members have been able to step in and provide extra support and energy to keep the work moving forward. And that was really intentional when we thought about sustainability. And so at the end of 2021, a pharmacy chain, oh, Gillian, can you go back to challenges? At the end of 2021, I just want to touch on how the pharmacy chain Bimart closed in Umatilla County. And in some areas, Walgreens has replaced them, but unfortunately there's one location in Umatilla County that permanently closed. And this was a big loss for the community. They're a rural community and they rely on the pharmacy for a lot of things, including a place where people were accessing syringes and buprenorphine. Prescribers have already noted a Suboxone shortage in the county due to the closure. Some people have been reporting that it's taking up to 2 weeks to refill prescriptions. We've been hearing this from neighboring counties as well. The team is currently trying to identify ways to provide support, including contacting the director of the Oregon Health Authority and pharmacists that are connected to our local universities, and ways that we can provide support for pharmacists and get increased knowledge bases and ways that they can address the shortage. In addition, we have experienced some challenges standing up adequate data management systems to collect information about all the work that's happening under the project. We're really trying to focus on minimizing burden, but still collecting the information to really highlight what's been going on in the county. We're working really hard on standing up those structures, and we continue to have regular data-focused check-ins. Next slide, please. Thinking about sustainability, we're just 6 to 7 months into this project, but sustainability has been on our mind since the beginning of the work. And that's really the reason that we did this collaborative leadership approach, making sure that as organizations and people may need to step in and out of the work, depending on the needs happening in their county, that the work can continue to move forward. And we've already seen that happening. There's also been this bi-directional information sharing and support, creating buy-in, making sure that people are getting their needs met and getting a benefit from joining our discussions, as well as them sharing some information with us. We really hope that the service delivery model and other resources that we're currently developing will be things that can be sustained over time by the local organization. So we're setting them up with that intention. That'll be easy for updating, and we're doing capacity building around data management and training around that to ensure that there's sustainability in data. All right, next slide. Okay, I think that's all the information we have. And here's our contact information on the slide. And I'll pause there to see if there are any questions.
Thanks so much. What a great collaboration and all the amazing work that you guys have done. So a few questions I came in from the chat. Liz Sweet asks, I may have missed this, but what organizations employ the peers?
I can take that unless you want to, Jude. Oh, okay, so it's a variety of organizations. Many of them are actually behavioral health treatment organizations. Some are harm reduction providers. Some are peer-run recovery organizations. There's a health department, and a health network. So it's a pretty wide variety. The OHA really chose based on who in the community was most able to employ peers or already employed peers. I don't know if there's anything you want to add, Jude.
Yeah, I mean, I would say when we worked with the pilot, we intentionally had multiple different places. So we had a behavioral health one, a public health one, a community-based organization. And I think what we learned in the pilot and have learned as we've expanded is it's who's ready to do the work in a particular community. And Oregon, it has a significant number of counties that are rural, and we also have frontier counties that are very large. And so really kind of who is ready to do the work. Any partners are welcome to come to the table to work with the peers. And they've been very, very just figuring out how to do that, like working with convenience stores, which was where one of our peer programs started a syringe exchange and placed the first syringe disposal box in their county on private property at a convenience store, at laundromats, with food banks. So it's really, we support our Prime Plus sites to figure out how to implement in the local community with who is there. And yeah, they are permanent employees, and we are working with how we write the contracts as part of one of the things that we've learned.
Thanks so much. Another question came in from Cassia Lawrence. Could you share more about the plans for peer-assisted telemedicine HCV treatment? How are you hoping that would work?
So Gillian, I will start and you will do cleanup. Is that okay? So like I said, so Oregon, we are a Medicaid state with no restrictions. And that being said, It's really hard in some counties to find providers who will prescribe medications to people who are using substances. And we have found that to be true in some of our counties. And so during kind of our, debrief of our Oregon Hope work, we said, hey, why don't we try to do this telehepatitis C treatment arm? Let's do peer-assisted access to treatment. So we were doing that through Oregon Hope. And sometimes what you find when something is really successful is it's time to try it outside of the context of a study. And so we started to do that. And that's called PATH, which is peer-assisted telehepatitis C treatment. And so we are in counties where we don't have strong current provider challenges. So we continue to train providers. We have an echo. We're doing everything we can to get providers in these rural counties. They're not always staying in those rural counties, even when we find them. So in a county where the Prime Plus peers are, the team says they would like to do peer-assisted telehep C treatment, we are working on a protocol based on the work from Oregon Hope to bring on the peers and connect them to a team of physicians at OHSU who have agreed to do telehep C with the peers. And we are hoping that this will work because the peers, when you think about the work that they're doing now to support people, if we have an interested and willing peer team, they can help drive people to get confirmatory labs. They can drive people to get the appointments that they need done to qualify for treatment in our state. They can check in with someone during treatment. They can help problem solve. They can help when they can help someone find stable housing. They can find someone who is unstably housed because they're in the community working with people in encampments. So our peers are really, our thought for PATH is that we are finding Prime Plus teams that are willing and interested in doing this. We're going to plug them in and treat as many people as we can and see what we can do while we continue to do our echoes and try to get more treatment integrated into primary care. I think at some point, you just start doing what you think is going to work to get people cured. And that's it.
That's good. And I can add some functional logistical details if it's helpful, the way it's worked in Oregon Hope Study and with our first PATH or Prime Plus site that has non-study site that has jumped on board. And it's required a lot more coordination than I think for Oregon Hope Study, OHSU and Comagine kind of did the coordination, and we'd hoped that some of the sites could do some of the coordination that needs to happen first so that peers are set up. And it's a big ask. So I think we are recognizing that the state, like there may need to be some more state level support to get the coordination piece in place, like working with setting up a lab, developing a lab relationship, getting blank lab forms, completing the forms. The peers are trained to trained by clinicians to fill out a form that helps direct which types of labs are going to be completed. The clinician directs orders the labs, but the peer is the one who helps ask the questions that make it happen. They also have to connect with their CCO, their kind of accountable care organization, to make sure that they're taking the steps that would get both the testing and the treatment reimbursed. They have to sign people up to get them enrolled at OHSU. So there's a lot of prep work, but the peers are ready and willing. And then other pieces are locations for mailing, setting up locations to mail the Hep C treatment. The actual medications is challenging for many people who are unstably housed. So the sites need to set up lockers and a locker system and have rules in place for that. So there's a lot of setup work, but once it gets rolling, it seems pretty seamless. The peers also they have like iPads or that they can bring to help people connect, or smartphones to help people connect to the providers, and they join them for those calls.
I would say for our Prime Plus, our peers really helped us. One of the their taglines is, any positive change. And I think really, when we were setting up Prime Plus, I think in the midst of COVID, it was just how do we keep moving forward? And now I feel like we turned this corner where we had wanted to have this discussion about Hep C with the peers. And because we couldn't actually get Hep C testing, we couldn't use the rapid test because of COVID. Our health departments were overwhelmed because of COVID. Like hepatitis C became, if you can do it. So that's partially why we only, we have like, I don't know, 72 something people through that. But now it's great in that peers are like, why aren't we doing hepatitis C? We need to be doing hepatitis C. So in some ways, we know we're ready. And I think the experience and Comagine's experience with the Oregon Hope study, and then we're looking at dry blood spot testing. So looking at kind of the collaboration that we've built in Oregon, it's been easier to say, we think we can do this. It's just going to take time. And again, this is all because of SAMHSA allowing hepatitis C work and peer work, and the syndemic model, the support of the syndemic model by SAMHSA has allowed this work to continue in beyond 1702.
Thanks so much. And I saw that Gillian put in the chat that they've developed a path model and it's in progress. So maybe in the future you can share that with the group. Definitely helpful to have resources and tools for other jurisdictions. It's just really amazing the peer collaboration and all the work that's being done. I was interested in just for people who are just starting off, jurisdictions that might be just starting off, like how did you set up the referrals, like more details on how you set up the referral services in the very beginning? Like, did you send out emails? Did you attend a meeting or have a good point of contact? But if you could provide a little bit more details about that.
So Gillian, you want to go and then I'll add? Because it's an ongoing process. It actually never ends.
It really is. And there's like community level work and then state level work, and they're both essential.
And
Yeah.
health system work, our CCO and hospital partners who are more recently interested. I mean, I think we started with I'm just trying to remember, it was so long ago. We started with the each site and having them think about who they were connected to. And then we, worked with at our training, our peers. They actually developed most of the language that we use. The kind of, they have like, 4 questions and a statement, or 4 statements and a question, which is, I've been where you've been. I have access to resources, and their question is, how can I help you? And I think really approaching the work, that work has been really local. And then when we have challenges, like with a lab or a system, then we kind of kick it up. And so it really is about connecting and moving up and down kind of that chain. But we recently were able to meet with our hospital kind of best practice team and talk with them about Prime Plus, and we were able to engage with our sites, and we're able to kind of walk in with like, here's their experience of how much access they have to your hospitals. I mean, it's really individual, and that's why the onboarding is so important.
Yeah, we're hoping to connect directly to support connecting directly with each of the hospitals. I think the hospital challenges have been real with the sites, especially during COVID. And so some sites have just repeatedly made presentations and gone, and like some sites have been able to just like show up and say, we're the peers, we provide support here. And the hospitals haven't kicked them out. And others, it's just been, they've had to have like a formal MOU before they set foot in the door. And as Judith was saying, so we presented for a set of our Oregon Health Leadership Council, which is the payer, a lot of the payers, the CCOs, commercial insurers, other major health systems. And so that was an effort to say, okay, still not getting hospital level access. Can we get the layer above them to kind of pressure the hospital, their hospitals within their regions or within their systems or kind of payer systems to support that. So we're kind of trying it from both sides, I think, from all sides. Yeah.
Yeah, that's really insightful, just approaching it from all different angles. Thank you. We had a question come in from the chat. We have struggled to get our behavioral health colleagues to use SOR or other funding for infectious disease services. Do you have a one-pager or something I can share with them to help make the case that this has worked in a neighboring state? I think this is from Washington. To contextualize further, we in public health are in a separate agency from the behavioral health bureaucracy.
So yeah, that is a me question. So I'm actually in the behavioral health system now. I'm on a job rotation over there to help integrate harm reduction into our behavioral health system, integrated system of care. I mean, we don't have a one pager, but I think that if that's helpful for people, I think we could do that. It has been, and I know that came from Emily. Emily, I know you've also been in Washington a long time. It maybe not. I just when you're in a whole stop digging, maybe you haven't been, but I think you've been there for a while. I think it's about, for us, it was really getting buy-in on the syndemic model, and getting buy-in on the syndemic model is an ongoing thing, because the second, I think you have to buy into the syndemic model when you have money and when you don't have money, and you have to share, and it's really hard with programs and divisions and all of that to kind of get that institutionalized in your institution. And I think in some ways, I think we've been fortunate in that people who've done the work are still kind of in those areas. And the syndemic model isn't just something that public health talks about, it's something our behavioral health partners talk about. And I think it's something that I don't know how, because it doesn't always work. We're still being recorded. It doesn't always work well for us. We work at it. It's this relationship. And we're just starting to try to work together to do the kinds of work. I can send you kind of the three models conceptual models that we share and developed through Oregon Hope, and then one in partnership with our health systems division, state opioid response, because we were trying to figure out who's in what lane and what are they doing, and where do we swim together and where do we work separately, and then how do we connect this whole substance use continuum of care. And I think one of the biggest challenges is the term prevention, because it can mean something very different when you're coming at it from a behavioral health side than when you're coming at it from a public health side. And I think we need to learn to speak each other's languages, and that is really hard to work across divisions. I would not say we're doing it perfectly. And some days I feel like we're not even doing it well, but we still show up and continue to do that. But I think if we don't start addressing substance use, if we don't start working together, if we continue to stay siloed, we're going to continue to experience that inequities in health that people who use drugs experience. And we'll never eliminate hepatitis C in Oregon without doing the really hard harm reduction work and having discussions about what harm reduction is, and things like safer smoking supplies, and all of the very difficult conversations that sometimes it's really hard to have as state people. So I don't know if that answered your question, but it has been, yeah. Oh, you've been there 4 years. I think we've been working on the syndemic model, Gillian. How long? 5 years?
A long time. Yeah. I think
Yeah.
so.
And literally
Yeah.
this morning, still explaining it to someone, like, this is how we think. We have to think this way because, you know, when I apply for the CDC grants, even I talk to my behavioral health partners, even if it's infectious disease, because we are linked in a syndemic model, and I talk with them. And when we do our we're preparing for the SOR grant, SOR3 to drop, and we've started having discussions about HIV and hepatitis C and STI screening within the SOR grant, because we know we cannot help people be healthy if we don't do both, if we don't address substance use, alcohol use, including that in substance use, and infectious diseases related to substance use and not just injection drug use.
And I could add something from an outside observer of the process of behavioral health and public health coming together. One piece that in my observation seemed to be helpful was that early on, like individual to individual, like Jude as an individual within public health, connecting with and forging connection with an individual in behavioral health who both recognized you were doing similar work like this on the infectious disease side. You all were with Oregon Hope and with the Prime Plus Eastern Oregon expansion, like starting to do this work, doing around peers, harm reduction services, community outreach directly to people who use drugs, while at the same time behavioral health was starting to fund through various ways people to peers and to do outreach to people who with active drug use, and recognizing that that was essential. So it started to seem like you're funding people reaching out, doing similar work in the same counties. Isn't there? It seemed to make more sense to come together. So it didn't seem like, Jude, you had to go to behavioral health and get them to buy into something that was already happening. It just needed to happen in a more coordinated way.
Yeah, we were in a meeting trying to figure out how to not step on each other's toes. And I remember saying, aren't we just trying to keep people alive? Like, that's our definitely shared goal. And it kind of grew from that. And, you know, Save Lives Oregon was actually named by our community partners, because it's like, we don't need to have anything really hard to pronounce or some kind of funky acronym. We're just trying to save lives. And so getting centered in why we're doing this work gets us through, but it is a challenge with any state system, for state groups to talk to each other. And substance use is I'm going to use the word wicked issue. And I think that sometimes what we're doing on one side is not supporting what someone else is doing on our same side. So I think really we're trying to figure that out right now. And it's painful. It can be a painful discussion.
Thank you so much. So we're at 3:58 p.m. So at this time, I'm gonna ask the audience if you can fill out the evaluation. There's a link that was shared. And yeah, it's really important that you fill it out, because it just helps us improve our technical assistance and how we can better serve you to provide resources for viral hepatitis surveillance and prevention. And I just want to thank our speakers, Jude, Gillian, and Erin. Just amazing collaboration and just so many different partners working together towards this effort of syndemic just one health and overall well-being of our population, and integrating that with hepatitis C testing and treatment. So I just want to thank you all for sharing with us your work and sharing all these resources that can help all the other jurisdictions provide services for viral hepatitis. So thank you so much.